So all right, welcome everyone to our latest episode of Documentation Dismemberment. Today we'll be doing a outpatient clinic case. And so no disclosures as usual. Objectives remain the same as usual. Just a typical reminder that history review systems and physical exam documentation no longer have any specific requirements. It's all about medical decision making, of course, which is the focus of what we are going to do and talk through in this case. All right, so jumping right into the HPI.
Blame it on the bingo.
Any thoughts on HPI? It's an interesting HPI.
Yeah.
Is that it?
Well, yeah, that's what I'm wondering. Is it?
Okay.
It is it. Okay. I thought the weight loss part was just.
It doesn't really state, I guess, what the actual complaint was, other than coughing, sort of, so everybody knows. It's in that third.
Yeah, so the chief complaints addressed in the third paragraph.
So you could have expanded from here today for an acute visit to here today for acute visit for whatever, and have it just right up top there.
How far after
Is she-
the 1024 is this? I guess that's pertinent to what's going on, so it's important that's there.
Good point.
Is the strep positive?
It's mid-November,
Okay.
so say 2 weeks. So it's about 2 weeks after the screen for strep. Had completed the 10 days of augment, so it wasn't too long after that.
Just right.
Yeah.
Just right.
I mean, yeah, the weight loss is kind of a random thing, but it's just one of those things. If you catch it, what do? I mean, you kind of have to do.
Was it intentional?
The
I'm
strip
saying-
was so bad they couldn't swallow.
No, I think she's there for weight loss. I bet she. They're head kicked by increase.
So I think that becomes the question in it is what kind of weight loss is it? Was this unintentional? Was this intentional? The documentation is not exactly intentional in describing that. So yeah, I mean, there are some, I mean, ultimately, from an HPI standpoint, it's billable. From a clarity of documentation, it could be a little cleaner. You know, I think that third paragraph actually is pretty good. It's odd that it's below that one, but I can see if you were reviewing the other note and you're typing that as you go before you know the rest of the story. Yeah, it makes sense from a logistics of how you did it. Of course, putting vital signs in the HPI
Super accurate. based on
is a
what's
red,
next.
it's a red flag. It's like, it's just, it's a lot of expended time. You're not gaining much. Because then you do run the risk of putting it in there inaccurately, which we have seen previously multiple times. But I do think keying in on the weight loss, that's one thing that will burn you medical legally at some point, is not paying attention to weight and weight loss, and especially in a random person who just kind of comes in for something else, especially if they don't follow up. Because the 126 pounds down to 121, I mean, that 5 pounds, not that big of a deal, but if you only weigh 120 something pounds, it does become more significant.
5%. I think they got it in my son, it's 5%.
All right, so moving into the history section. Any questions about any of that? Anything jump out as concerning?
There's some
Mr. Dawes,
maybe causing her weight loss.
she's a smoker, got cough and weight loss.
Yeah, I mean, so that smoking, cough, weight loss, COPD,
Concerning.
also has the heart failure on furosemide.
She's already 120 something pound. That's really low. BMI maybe almost 30.
She's like 4 foot tall.
Doesn't matter.
So we'll jump into the review of systems physical exam here and see the vital signs. What's her BMI is 18.5.
She's okay.
There's the answer.
Yeah, she looks like-
Barely okay.
Edema on her heart.
What are your thoughts on physical exam?
Maybe you could have looked in her throat if she'd been treated for amoxicillin and still got a cough.
Could be dehydrated.
Sore throat wasn't a complaint, was it?
No,
No,
it was
it's cough,
cough,
shortness of breath.
fevers.
So I mean,
But you put that in there. You put it in there, she treated amoxicillin.
This is COPD disintegration.
yeah, I mean, I think it gets into was any of that even, like, was that line pertinent in the end of it? Doesn't seem like it. Other than to note that she's recently been on antibiotics and probably might not want to do the same. Same antibiotics. I mean, I think the physical exam, I mean, does it touch on the things that really she came in for?
Yeah.
Yeah.
So, I mean, the lung exam, honestly, the lung exam and the rhinorrhea piece is really the crux of it all. Everything else becomes a little bit secondary to that. The
The edema's good.
the edema's good because it shortens of breath and a cough. It could, it's with a history of CHF. It could be CHF. So, I mean, you really could trim that down to that much and be billable. I think she did have a history of AFib.
Yeah, she's on it.
Valid question.
Questionable. Yeah, so I do think probably some, you know, she's a little tacky at 101, which is mentioned in the HPI, but then there's not a assessment of like there's no irregular, there's no assessment of our rate and rhythm on exam. A minor issue, but nothing glaring, because 101 is not the end of the world. You know, if she's 120, it'd be much more important to get a more thorough cardiac exam. But you really could turn loose musculoskeletal, skin, neuro, abdomen for this. Any other thoughts? Going to assessment and plan?
You're exposed to COVID.
You need thoughts or questions here on assessment and plan? Please. That's all the assessment.
Makes
and
it
plan.
seem like the weight loss is unintentional.
It's
But
treated,
it's
it's
not.
treated as unintentional, but it's not specific.
We don't know what's exactly the differentials here.
I mean, it's probably COPD.
Yeah, just increased work of breathing, yeah.
No.
I mean, you think, who knows?
In today's world of GLP-1s, like if you're a coder looking at this and you just see weight loss, is this better or worse? Like if you were a coder and you knew nothing clinically. Based on that treatment, but then you can't expect a coder to make the inference that you're telling them to increase protein, drinking this stuff to actually gain weight. There's nothing there that clarifies that that problem's actually worse. Because it could be the other way around. It could be,
Lose weight.
could be trying to lose weight and this is an improvement. So I think this is one where you either need to use the ICD-10 code for unintentional weight loss, which is actually it's the same code. It's the same code, it's just if you search that in the problem list, you put unintentional in it and you don't have to then document more in your note. Or you just document in there, or just say worsened. This is one, putting a modifier on that would help a coder look at that and go, okay, this is a chronic problem that is now worse. But I don't think you can really get there from what's in the documentation. What are the thoughts on exposure to COVID? So, and also too, I think we've mentioned, we think it's due to COPD, we think it's due to this. There's no statement on what is doing from a coding standpoint. Could it help you if it's a differential yes, if you listed it as a differential diagnosis for weight loss, COPD, cancer, whatever you want to put in there. Like that actually helps build out your diagnosis section because you've considered all those. If you list them in differential, then you get credit for it. Because you certainly that thought process went on in there.
There was no mentioning of like the COVID-19 in the HPI, right?
Right. So that's, moving into number 2, exposure to COVID-19.
Just kind of comes out of nowhere.
Not mentioning HPI.
When she went to bingo, therefore
Look
you're
at that.
exposed
I mean,
to
that's,
viruses.
yeah. Bingo equals COVID-19.
That's a smart, blame it on bingo.
Yeah.
Someone's,
So what's another issue using exposure to COVID-19 virus as an ICD-10 code?
It's not a diagnosis of it. I mean,
it's a
Z code.
It's a Z code.
So there is no billing for it.
So it's tough to drop that in a bill.
been better to bill like COPD with exacerbation or without.
Or
then
whatever.
Or with
or whatever.
possible
MRI.
success.
Or you can use it if you want to, but that's when you have to have differential diagnosis listed below it. This could be COVID-19. It's obviously COVID-19 ruled out.
Patient has cough, so you can put the cough and put whatever you want under
You
the
could go
cough.
with
That would be
symptom
like,
and cough and then stick differentials with it. A lot of different ways to go about it.
On this one, could he wrote COVID flu or he or she? and then pneumonia. That's three different, like he wrote out three things right there.
Yeah,
They're going to.
yes. So if you just made a statement of differential diagnosis,
But you gotta put that in there.
COVID versus flu versus pneumonia versus viral URI. Like, I think I have a doc phrase in urgent care for that.
Oh,
I mean,
I see.
at some point, you might as well just have doc phrase and stick some differential diagnosis in there if you're working in urgent care, because the differential diagnosis on half the patients. So you're just thinking about, having worked at urgent care more, I've thought more about, like, you really do need doc phrases for some of this stuff. It's, this complaint comes in, boom.
That's where you take 40 of them a day.
Yeah, I mean, here's your differential diagnosis. You can get higher billing for less work. You're, the same work you're doing, but less time documented.
Do they get paid by billing over there?
They don't. Somebody, the people that pay them do.
Now, is there a difference between saying viral URI versus COVID flu, naming out every virus?
I mean, I guess you can get credit, but I mean, you can only get credit for so many. Naming out every virus, though, those are all self-limited problems.
Mhm.
Except for human metapneumovirus, and I'm sure that brings you up. Yeah, so I mean, I think, there's a lot of differential going on here, a lot of work being done. Exposure to COVID-19 doesn't really get you credit for the work being done. I think that was kind of why I thought this was a good case to talk through, because we'll see how it plays out, but obviously continue inhalers, refill inhalers. So there's some medication management done in there. So that's helpful, right? So somebody said it too, like, what other so a patient with this many chronic medical issues, you can tag those in here as diagnoses, even if they don't have, I mean, you got a respiratory issue and you got a patient with COPD. You just always need to click that one and stick it in your note, because you had to have thought about that.
You can put like
I mean,
CHF on there.
the inhalers and the refill inhalers are addressing the COPD.
So just put it in.
Could be an exacerbation. Something simple as that. Now you've got a chronic problem with a potential exacerbation. Suddenly, now we know that rings the bell for level 4 just by itself with nothing else. Any other questions about this one?
It's just X-ray.
You what?
What if it's X-ray?
Yeah,
Thanks for blocking out my name.
You gave it away with your bolding.
Gave it away from the second I saw it. Everybody knows my form.
sorry, I didn't like it.
I'm suing.
You're saying, well, it's my turn to be done.
Forget about taking your own name.
Give me his name. I need one.
I'd say you admitted to it the first slide.
I know. I'm happy to.
Self-incrimination, Trump.
We'll talk about my president.
Yeah, but you could have been seen in for an acute visit and Kodak could have been there.
That's true.
That's true.
See, look at that. There's my attorney right there.
I'll send you my bill.
Nothing exciting there, other than
Exclamation points.
exclamation points.
Thank you.
Potentially incriminating use of Dr. Kodak. There you go. Allegedly incriminating.
Slander.
Did you call them?
Got it like a week afterwards.
What days after. All right, so medical decision making, as we know, based on the 2021 guidelines for outpatient, this is based solely on medical decision making. Think of it as the DDR, diagnoses, data, and risk are the three categories of medical decision making. Of course, each component gets assigned its own level, and then the final MDM level is based on the highest 2 out of the 3, so you don't have to get all 3 of them to bill at the highest level possible. So example there, you got a 4 and a 4. Even if the risk is level 3, you can still code that as a level 4 overall. So moving into the diagnoses section. That's just kind of, we'll use that as our refresher, but we're always trying to get level 4s in the clinic. Outside of a residency situation, of course. Don't get to build level 4 unless the attending sees them, so. But really trying to remember that 1 or more chronic illnesses with exacerbation gets you to level 4, 2 or more stable chronic illnesses get you to level 4. And then it really takes an acute illness with systemic, in this case, 1 acute illness with systemic symptoms will get you to level 4. So just thinking about that in this page of presentation, what would be the most likely acute illness with systemic symptoms that you could get out of this?
COPD.
Oh, COPD exacerbation, short of breath.
Wouldn't that be a 1 or more chronic illness with
Yeah,
exacerbation?
but it would yes, it would also go there too, so. I don't, yeah, I guess you could argue that one either way. It's easiest to say it's exacerbation, but I don't know if pneumonia with systemic symptoms, you would really have to make the argument, it's not hypoxic.
Heart rate.
It's short of breath, it's a little tachycardic. You'd have to play it up a little bit, but I think you could probably get there.
The weight loss could be one that there's new problem with uncertain program.
Right, so it's not real clear what the weight loss is. I think that gets back to was it chronic and worse, which would be a chronic unstable, which still gets you to a moderate. Or is it an undiagnosed new problem with uncertain prognosis that we're working up for the first time? It wasn't treated like an undiagnosed problem that we're working up for the first time. There's no TSH, there's not a lot of, cancer workup and that kind of stuff. So I would assume that it's a chronic with progression, but that's not stated, so you're not ever going to get credit for it. They're going to look at that, and I don't even know I'm not sure where you would put that, but that's the next slide. So it's kind of definitions of different kind of diagnoses, which we come back to if we need to from a reference standpoint. So what would you call this weight loss?
Nothing.
You say
Said
nothing.
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 mean,
That's better. It's better than nothing.
I think it might meet that acute concern with unknown diagnosis or unknown complications.
I think from a coding standpoint, if you're looking at this, you would have to call it you would probably actually end up having to call it a new diagnosis, uncertain prognosis.
Yeah, that's what I would say.
because
There's nothing else to say otherwise.
There's nothing else to say otherwise. Although it doesn't say whether it's good or bad weight loss.
Right.
So.
Change.
From a pure coding standpoint, I'm not really sure what you do. Because if it was stated this was a bad thing and getting worse, then it's
chronic.
or just stating that this is unintentional would have got you to uncertain, undifferentiated diagnosis, uncertain prognosis. If you said it was worsening, then it would at least get you to chronic with progression.
Or what was your BMI?
18.5.
It's 18.
That put it underweight, right?
Barely on that.
18 would be the official cutoff.
Mhm.
So no.
But she's hidden that.
But my guess is this is a chronic problem it's just watching this go down going, there is a problem here. It just hasn't hit the.
You can put like underneath it, like unintentional versus underlying COPD, maybe cancer, maybe something else, and further workup required.
Likely. Associated.
Yeah, I think that highlights what do we do? All right, how about exposure to COVID?
That's 5.
It poses the risk in bodily function. Can't go to bingo anymore.
COPD.
You might need work.
Yeah, so I think, is this a self-limited, is it minor? I mean, that's really an exposure, is it even that, because it's an exposure?
Right.
It's not really a symptom. So what other diagnosis could have been listed in different, before I added the problem list?
COPD.
Yeah, COPD being the big one. So what level?
Tachycardia, maybe you can put in.
Oh, I mean, you put all kinds of stuff in there, but you have to, then you still have to tie them back to why they get you to a level 4 diagnosis. Like a 10 level 3 diagnoses doesn't get you to level 4 if they're acute problem. You gotta have 2 chronics. If you can have 5 acutes, but if none of them hit that systemic symptoms, then you don't get there. So what level would you give this from a diagnosis standpoint?
Close the 3 and close your eyes.
Is it build it a 3 and close your eyes?
Like straightforward that
Do you need caffeine?
too.
You said too much.
Yeah, I mean, I think it's a level 3 with the potential of gotten it to a level 4. I think that's probably what a coder would give you, but I could also see.
You
where-
order X-ray or the labs, you get refill medication, but you didn't put the right diagnosis there. That's what make it like level 3, but
But he could have managed 2 chronic illnesses, chronic weight loss, and then chronic COPD with the refill of medicine.
Right, if it was listed as.
If it's listed.
diagnosed. So now moving to data. If our data is gonna focus on that level 4, use 1 of 3 categories. Category 1 is all about reviewing notes, reviewing results, and ordering tests. Independent historian can get you credit there as well. That's kind of our bread and butter in the clinic. It's category 1, so you need to remember that. If you remember nothing else, remember that one. Category 2 is independent interpretation of test. Without having X-ray here, it's really hard to get that in the clinic. EKGs, of course, get billed out as their own, so you can't count those. So really, it's X-rays about your only option. And then category 3 is discussion with management or test interpretation from an external provider. So that's if you're having to call a surgeon or call a radiology or somebody else, that's a pretty unique scenario in the clinic. So it doesn't happen a whole lot, especially on a level 4. Those patients are not going to be level 4s, hopefully. All right, so now breaking this down from a data standpoint. Gave away the answer there. I thought I had that triggered, so. All right, well, there you go. Category 1. So what are the 4 things that go towards category 1?
The 3
Chest
tests,
X-ray.
CBC, BMP, and chest X-ray. And then
He looked at a note.
yeah, he
from
looked
the-
at
COVID and flu.
the last
negative.
acute note.
Did it really state?
He didn't
the
say
note
they
was
did
looked at?
that. Yeah, just said that.
I would like you should say like I reviewed
They
the
could have
notes
told
from
them that they
that
got
day.
diagnosed on the
It doesn't say the
That's
note
true.
was
That's
reviewed.
true.
It
That's
just
true.
says what happened, which the patient could have told. Pretty sure the note was reviewed, but if you don't say it, they can't give you.
Does it count if you're reviewing your own note?
No.
I didn't think so.
Can't you just, I have a dot phrase that says dot, lab reviewed, medication reconciled, comma, chart review. Does that count?
What does it say?
That's all it's,
It says nothing.
it says that it has to be detailed.
I mean, if your
ED
coder's really gonna, explain this and say.
Be careful. Stop down.
I mean, you don't have to say anything grand. I mean, note review, 1024,
Note
did all
review.
these things happen, common note review. You're done. You want dot phrase, note review would be
It's too broad.
the thing to put in there.
Do you have to say anything
If you want to do it quicker.
that happened in that note? Or could you say note from 11/24 reviewed? You have to put in details to show that you actually reviewed it.
In theory, I think you would get credit for that, but once again, That's that's your coder is having to make a decision on whether they're comfortable.
Yeah.
You reviewed it. Well, what did you, but how did it impact your medical decision making? I still think if you don't tie it back to how it impacts your medical decision making, or it doesn't have an obvious impact on it. I mean, I think looking at what antibiotics a patient was on recently, that's obvious enough of why that's pertinent. But if you just said note reviewed, then you can get there. In a chronic, reviewing cardiology note, reviewing that kind of stuff in their last visits, if you're dealing with their chronic issue, those are pretty easy to get credit for without explicitly stating things. But I think if you go with the fact that everything really should tie back to your medical decision making, which should tie back to your HPI, it flows as one story, you'll never have problems. That doesn't say that you're not gonna be on the fringe sometimes and hope the ball bounces your way, but I feel like blanket kind of statements that don't say a whole lot are probably not going to get you. I mean, do you really want, if somebody comes down here and pulls 10 charts, and they find that same statement in 10 charts, and that's what was up, that's what allowed somebody to upcode half those charts, do you really want to be defending that? I mean, if you do it here, if that's here and there,
Right.
but that's the way you're getting an extra category 1 to squeeze a level 4 out. But I think you have to think about it. If somebody went and pulled 10, 100 of your charts and looked at all of them,
It's gonna say that 100 times.
and it says that 100 times, and how many of those times was that the only reason you got a level 4? Yeah, I would not want to be sitting on that. If you're doing everything everywhere else to get level 4s, then what was the point in that?
Your coder is only part of it. You gotta watch what the CMS coder would say.
Oh.
Or the insurance coders, because they do simple math. They'll look at 100 charts and say, well, you've got 2,500 charts and 10% of your 100
Mhm.
are overcoded. So 10% of your 2,500 are now overcoded.
Yeah, they may only audit 100, but they're gonna penalize you for the full
For
amount.
your- Wow. Because that's your habit.
Okay.
So having overly inclusive blanket dot phrases just looks like a bad habit. And if you do that and you ever get audited, they're gonna see, well, you do, this is clearly some dot phrase you just sticking in every chart. You're really doing that? And if they can ever catch where you didn't really do it one time, or something in yours conflicted with that, I don't know if they can pull those records, but in a unified record, sure, they could ask for whatever they want.
Yeah.
And they go, well, you clearly didn't even address what was said in that note. I mean, you just won't get caught in that. It's not to say that these audits happen regularly, but
So if you worked at, let's say, an urgent care, that it's just dot phrases, how do they not? Like, is it not the same?
I mean, if you have nothing but dot phrases,
Yes.
you're on the limb.
Okay.
I mean, if everything about it, I mean, I guess you could, if your dot phrases are the same, let me take that back. If you've got 100 dot phrases, so all your notes look very specific to the diagnosis you're actually taking care of, then you're probably gonna be okay.
But if it's just a
But
standard dot
if
phrase,
you get dot phrases that are way too inclusive, and you're using them on strep throats and pneumonias and COVID, and they see them in the same chart for different diagnoses, I mean, it doesn't sound like a red flag.
no, it does. That's why.
Yeah, so I mean, to me, but if you have a COVID dot phrase, and you have a strep throat dot phrase, and you have a pneumonia dot phrase, and those are only used in those appropriate diagnoses, and nobody's going to jump on that. I think it's when you start trying to use the same dot phrase, they pull 100 charts and the same dot phrases in 50 of them. I mean, you're not expected to see the same thing over and over and over.
Right.
Only if you're running an obesity clinic and that's all you do for every patient. Well, that's gonna be the norm, to use the same doc phrase over and over.
No, I just meant that word right there, the simple phrase of lab reviewed, chart reviewed. That's what I meant.
You're still not tying it to
You're still
that
not-
decision.
What if I put a date behind it? So I go back in the chart, I see a cardiology dropped at 10/24. 10/24 lab review, chart review. That's safe.
Mate, you're still not gonna get credit for labs, like that statement in of itself, well, you're not tying them into how they impact the medical decision making for that patient.
Well, when your assessment and plan, if you saw a little jump in like hyperlipidemia, then you start with a statin, it's implied. Well, it doesn't matter, tied in.
The implication doesn't matter.
Coders can't do implications, they
can't do
have to go on
implications.
explicitly what's written. So if you list a high blood pressure, but you don't say like hypertensive or whatever, they just,
They have to go on what is black and white documentation in front of them. And that's why it's important to work with coders to try to get an idea of how much. And is that to say that all coders are all created equal? No. I mean, some may be willing to take implication a little more than others. You just don't know.
Right.
So it's important in practice to talk to the coder and kind of fill out like where are the like gray lines in here? Like where is the spectrum that we need to be shooting for? So we have any category. So there's the other category one here that's COVID flu, because that's a combo test. You only get 1 point for that. So then obviously that, through the labs and chest X-ray. Had the chest, all right, so now category 2 is 0 because obviously there's no independent interpretation. Had the chest X-ray got done, same day and not 3 days later. You could actually go back and put an addendum in or put that in your note if you looked at it and did an interpretation. You get credit for that. Which is why you should put all your independent interpretations in any ED, urgent care, hospitalist note, because you're looking at those. You want to get credit for it. How about category 3?
0.
No.
0, yeah, when nobody else is talking. So yeah, no other external provider discuss this. All right, so that's a level
4.
So why is it level 4?
You only have to meet one of the categories.
Yeah, so you need 3 out of category 1. But you went above and beyond.
4 here.
So that's a level 4. I can be a level 5. We just talked about how that could be a level 5. If the chest X-ray was done the same day and you had an interpretation in there. So risk, the key to risk is prescription drug management in that level 4. So did this case have prescription drug management in it?
Yeah.
Refilled inhalers.
So, but interestingly, some thoughts I had, what does boost insured count for? I don't know. Kind of a treatment, but it's not prescription drug management, so. I think it's a supplement sign, so it's over the counter med, it's over the counter med / supplement, so it's a level 3. So thought that was an interesting point to bring up in this one. When you're thinking about that. RX meds are covered, that's a level 4. Chest X-ray tube use. What level it, but it's a risk. You're radiating them. Radiation is risk.
Level 4.
No, it's a level 3, I believe. Oh, no, it is. It's a non-extremity. See, this is one we've not actually covered. Because when you get into low is an extremity X-ray radiation exposure. But any X-ray that is non-extremity
It's high.
is actually a moderate. So that's where it, to me, so I guess thinking about this, extremity X-ray gets you a 3, non-extremity X-ray or non-con CT gets you a 4, and then contrast CT is level 5. So it kind of stepwise works its way up. I did not know that till I did this thing. Yeah. I never pay attention to the X-ray.
Yeah.
The CTs we talked about before, and we knew that one. But yeah, so interestingly, the chest X-ray actually gets a level 4 included by itself on a risk standpoint.
Even if you don't put the,
This was my note.
even if it's not, like, you don't put the explanation or whatever, the review readings.
Right, because it's risk, because the radiation.
Oh, yeah.
The radiation is creating risk to the patient. So therefore, you actually get more credit for it. I thought it's a little odd. It's pretty cheap. I mean, chest X-ray gets you a level 4.
Question.
Yeah.
Would an X-ray of the hips count as non-extremity?
I would argue no. I mean, I think musculoskeletal.
That would be.
Rib fracture, I mean, I would think non-extremity, so vertebral,
Mhm.
rib,
Chest.
chest. abdominal.
Right?
It's a great question.
If you're doing the hips, then it includes the pelvis.
If you get the pelvis.
Then you're gonna include all this gonads, right? Out of the organ.
Yes, if you got the pelvis, I would say yes, but if you purely did
The hip,
the hip, I would think no.
and they covered you correct.
It's an interesting question.
You'll hate me, but give me my level 4 RVU.
We also need to make prescription strength boosts.
So this is clearly level 4, based just off the chest X-ray. And the prescription meds, so double level 4.
So this is your regular clinic patient, and you knew everything already. Why say more words when less words?
You said a lot of words.
It's a very long HPI to still get a level 4, but you didn't need any of it. Uh-oh, she's here.
Oh, wait a minute.
Yeah, get twice on recording. So summarize, we had diagnoses, probably a 3, data 4, risk of 4, so our final E&M code assignment is a 4. So we still got paid here. No,
A level 4.
Don't sweat it. Down coded by being a resident. So.
At the end of the day, you put.
So now, our final translation to work RVUs, in the last 60 seconds here, before Beverly runs us off.
As we move the paper.
Oh, yeah, as we move the table, it's still logged into you, so. All right, so here's the just to do a comparison of the 213 to 214.
Sorry.
That'll be the police.
There you go, first bleep. 99213, general 1.3, work RVU, so 99214, it's 1.92. It's a 48% increase in value. Only a Black Friday sale, can you get that good of a deal? This is why we try to get forward, because 1.3 and 1.92 is a big deal. We're talking about trying to get
Chest X-ray
the
for everything.
Chest X-ray for everything.
That's right.
This is not urgent care.
That's a shoulder problem.
Thank you all.
Thank you so much.